Welcome back to the deep dive. Today, we are getting right into the thick of it, into the body's microscopic battlegrounds.
We are. We're focusing entirely on Chapter 17 from Focus on Nursing Pharmacology, all about immune modulators.
And this is, one of the fastest moving fields in medicine, right?
Oh, absolutely. The drugs here are either our biggest breakthroughs or, frankly, our most complex safety puzzles.
So our mission today is to take this huge landscape of drugs, the boosters and the brakes of the immune system, and just boil them down.
Exactly. We want to organize them into clear clinical facts so that you walk away with the most critical nursing safety points completely nailed down.
Okay, so before we jump in, we need to define our terms. We need a toolkit. What are the 4 core concepts we have to have locked in?
Right. Let's set the vocabulary. First up, an immune stimulant. Think of this as a high-octane fuel for the system.
Revving it up.
Revving it up. We use them when the immune system is exhausted or needs help fighting, say, a specific virus or a cancer. It's the gas pedal.
Okay, so what's the other side of that coin?
That would be the immune suppressant. These are the heavy-duty brakes.
And their job is?
To block T cells, to block antibody production. You're using them mainly to prevent organ rejection after a transplant or to calm down the fire in autoimmune diseases.
Got it. And the huge part of this chapter covers these newer biological drugs. How are they different?
That brings us to our last 2 concepts. Third, monoclonal antibodies, or Mabs.
Mabs.
If the immune system normally uses a shotgun, Mabs are, well, they're like precision-guided missiles.
Okay, I like that analogy.
They're cloned from a single B cell, so they react with one very specific antigen, incredibly targeted.
Which is why we're seeing them for everything from arthritis to cancer.
Exactly. And that leads to our 4th point. Recombinant DNA technology. This is how a lot of these drugs get made.
Right. We're not harvesting them from people.
No. We're essentially using engineered bacteria to produce chemicals like interferons that human cells normally make. We just need them in massive quantities for medicine.
Perfect. So with that foundation, let's immediately talk about context, specifically across the lifespan. The book really stresses how age changes everything here.
It demands extreme caution, really, at both ends of the spectrum. For children, most of these modulators just aren't recommended.
Not enough data?
Not enough data. But for the ones we do use, cyclosporine, for example, we often find that kids require higher doses than adults.
Wait, say that again? Higher doses for smaller bodies? That seems completely backward.
Oh, it does, right. But it speaks to their heightened metabolic activity. And the key takeaway for you is the vigilance it requires. Constant monitoring of GI, renal, and CNS function, and of course protecting them from any infection.
And for older adults?
It's sort of the opposite problem. Their immune system is already aging, less efficient, so they're more susceptible to all the effects, good and bad.
So even more monitoring?
Way more. Close monitoring of renal, hepatic, GI, and CNS effects. Baseline function tests are completely non-negotiable. You have to know where you're starting from.
Okay, let's hit the gas pedal then. Part 1. Immune stimulants. When we're giving a booster, what's the goal?
The core outcome we're chasing is pushing the immune system to fight harder.
Against a virus, a cancer.
Exactly. Or even just to help the bone marrow recover after something like chemo. The 3 main classes are interferons, interleukins, and colony-stimulating factors.
Let's start with interferons. The prototype here is interferon alpha-2b. How does it work?
So naturally, when a virus invades one of your cells, that cell releases interferons as a warning.
Little alarm bell.
A perfect alarm bell. The drug mimics this. It stops viruses from replicating and tells nearby non-invaded cells to put up their shields by making antiviral proteins. It also inhibits tumor growth.
Okay, and the uses are for some really serious stuff. Hairy cell leukemia, chronic hepatitis, malignant melanoma.
Yes.
But the clinical fact that's going to hit the patient hardest is the side effects, right? They sound awful.
They are, and this is the absolute high-yield point for any stimulant. The adverse effects are a direct result of that intense immune stimulation.
So the drug working is what feels so bad.
Precisely. You don't just feel a little off. You get a severe, really challenging flu-like syndrome.
What does that mean exactly?
Profound lethargy, intense muscle, and joint aches, myalgia, and arthralgia, anorexia, nausea. It can be completely debilitating, especially for a patient who's already sick.
Wow. And that's not all, is it?
No. We also have to watch for serious bone marrow depression and CNS effects. There's a real risk for depression and even suicidal ideation.
And there's one more critical safety flag we need to mention.
We do. These are often teratogenic in animal studies, so female patients must be taught rigorously to use barrier contraceptives. Oral contraceptives might not be effective.
Good to know. Okay, moving to interleukins. Prototype.
Aldesleukin.
What are these doing?
If interferons are the warning system, interleukins are the communication network. They talk between lymphocytes.
And aldesleukin is for what?
Metastatic melanomas and renal cell carcinoma. Its job is to activate cellular immunity, basically by cranking up the number and activity of natural killer cells.
And I'm guessing we see that same flu-like picture.
Yes, that systemic inflammation is there, but with interleukins, you also have to watch for respiratory distress, CNS changes, and cardiac arrhythmias. It's serious stuff.
Okay, last one for the stimulants. Colony-stimulating factors, or CSFs. The prototype is filgrastim.
These are your bone marrow boosters. Filgrastim's job is very specific. It tells the bone marrow to make more neutrophils.
So it's all about fighting infection, especially after chemo.
Exactly. It's about reducing neutropenia.
And what's the one defining adverse effect you'll see with these?
This is a great clinical tip. You should expect generalized pain and bone pain.
Bone pain from the drug.
Yes, and it makes sense when you think about it. The pain comes directly from the bone marrow ramping up production so quickly. You're literally feeling the factory turn on.
All right, that covers the gas pedal. Let's flip the script and hit the brakes. Immune suppressants.
Right. These are the drugs that let a transplanted kidney survive, and they're almost always given with corticosteroids to help with inflammation.
So let's start with the big one, the workhorse. T and B-Cell Suppressors, with cyclosporine as the prototype.
Cyclosporine is really foundational for preventing organ rejection.
How does it work? What's the mechanism?
It's so effective because it hits multiple targets. It blocks antibody production by B cells. It inhibits T helper and T suppressor cells. It just dials everything down.
So kidney, liver, heart transplants, but also some autoimmune conditions.
Yes, like severe rheumatoid arthritis or psoriasis.
This drug is obviously life-saving, but the trade-off is huge. What are the big overarching dangers you have to watch for?
The number one risk, the thing you always have to have in your mind, is the increased susceptibility to severe infection.
And the second one?
The long-term risk for developing neoplasms or cancer. Without that immune surveillance, the body can't clear out rogue cells.
And specific to cyclosporine itself, what are we monitoring?
We're watching for renal toxicity, hepatotoxicity, and hypertension. But the classic textbook side effect you'll see is gum hyperplasia.
Overgrowth of the gums.
Exactly. And a key clinical tip for administration, that oral solution tastes pretty bad. You can mix it with milk, chocolate milk, or orange juice to make it more palatable for the patient. Compliance is key.
Okay, let's touch on the other categories. What about immune modulators and interleukin receptor antagonists?
So an example of an immune modulator is fingolimod. It's pretty cool. It was the first oral drug for relapsing MS.
And his action is physical.
It is. It literally stops lymphocytes from leaving the lymph nodes, so they can't go cause inflammation. Then you have drugs like anakinra, an interleukin receptor antagonist for RA, which just blocks one specific receptor.
And anakinra has a huge safety warning attached.
A massive one. You do not combine it with etanercept because the risk of life-threatening infections just skyrockets. And here's the mandatory patient teaching point. Patients on this drug cannot receive immunizations.
Yeah, risk it.
Can't risk it.
Okay, finally, the monoclonal antibodies, the Mabs. This group is just exploding. Let's talk function, using bevacizumab as the prototype.
Right, Mabs are all about their target. You have ones like adalimumab that block TNF for arthritis.
The Mira.
The very same.
Yeah.
You have cancer fighters like trastuzumab, which targets the HER2 receptor in breast cancer.
Herceptin.
Yep. Then you have protective ones like palivizumab to prevent RSV in high-risk babies. And the newest class, checkpoint inhibitors like pembrolizumab, which take the brakes off T cells so they can fight cancer.
So when you're giving these powerful IV antibodies, what are the two big acute reactions you have to be ready for?
The first is acute pulmonary edema. The second, and this is a big one, is cytokine release syndrome, or CRS.
And what does that look like?
It starts like a bad flu, but can rapidly, and I mean rapidly, progress to shock and multi-organ failure. You have to act fast.
And our prototype, bevacizumab, what are its specific warnings?
Bevacizumab stops new blood vessel growth, so its black box warnings are related to that. GI perforation, hemorrhage, and severely impaired wound healing.
Makes sense. Okay, this brings us to the most practical part. Let's consolidate the nursing responsibilities for all of these drugs, stimulant, or suppressant.
This is where it all comes together. We have to start with a baseline assessment.
You can't put a car on the track without checking the engine first.
Exactly. You must get baseline renal, hepatic, and cardiac function tests, including an ECG before you start. Then you need to monitor the CBC periodically to watch bone marrow function.
And the temperature check, that takes on a whole new level of importance.
It really does. A small rise in temperature in an immunosuppressed patient is an emergency until you prove it's not.
So, in terms of actually keeping the patient safe, what are the actionable steps?
Infection prevention above all else, strict aseptic technique for any procedure. And then patient education is huge. Teach them to avoid crowds, sick people, anything that could cause an injury.
And let's hammer home that one classic drug-food interaction.
Ah, yes. The one every nursing student should know. Patients taking cyclosporine must be explicitly warned to avoid grapefruit juice. It dramatically increases the drug's serum levels, which skyrockets the risk of toxicity, especially renal toxicity.
So as we're evaluating the therapy, the transplant's working, the RA is better, we're constantly weighing that success against the risk.
It's a constant clinical tightrope walk. Stimulants fight cancer, but they make the patient feel awful. Suppressants save organs, but they introduce the twin risks of lethal infection and cancer.
The power to modulate the immune system is incredible, but the trade-offs are just so dangerous.
They are. And that brings us to the final thought, for you to take into your practice. The power we have means we can halt a crippling autoimmune disease, we can save a life with an organ transplant, but it always comes with that trade-off.
The suppressed immune system.
Always. So the constant tension for you as a nurse is this. How do we give this life-saving immunosuppression while actively preventing the lethal infections and cancers that this very suppression creates? That level of relentless vigilance, that's what defines great nursing care in this specialty.
A really powerful way to end it. We hope this review gives you the clarity and confidence you need to handle these drugs safely. Thank you for joining us on The Deep Dive.
We'll see you next time.